So I will continue with our cases. We move on with other types of fibrosis and other aspects of lung fibrosis. And this is an important disease which we see here. That's a fairly old gentleman with dyspnea exertion. And if you remember what I told you before, chest radiographs are not diagnostic, but they can help you to get a clue that you might be dealing with a fibrosing lung disease. And as you can see here, there's an elevation of both diaphragms, the right a little bit more than the left side, giving you the impression of a loss of volume. So this is the CT scan now here on the right side. And clicking through these pictures, you will see that the apical parts, it's not completely normal, but it doesn't look too bad. And going down, you see it's getting more and more advanced. And here in the basal part, you see quite some changes. And this is what I describe as honeycombing. You see these cystic air spaces. Yeah, and neighboring cysts are sharing the walls. There is clusters of cysts. It's important. It's not isolated cysts like we saw before in the case of Vanessa van LIP. These are clusters of cysts, and that's then by definition honeycombing. And what is important in that context is honeycombing shows a clear basal predominance here. So this is very suggestive of a UIP pattern, usual interstitial pneumonia. And I told you before also, whenever we see honeycombing, we have two main differential diagnoses, which would be UIP, usual interstitial pneumonia, and hypersensitivity pneumonia. And distribution is everything. So here we see a basal predominance, which is more likely UIP than hypersensitivity pneumonia. But then this could also be something else. So we always need to exclude hypersensitivity pneumonia. We look for diseases, signs of disease of small airways. I don't see any nodules. I don't see any air trapping. So this fulfills then the criteria of a UIP, because we see here these reticular abnormalities and minimal ground glass in combination with traction bronchiectasis and honeycombing in a basal and subpleural predominance. And here next to each other, the two main differential diagnoses would be honeycombing and UIP. And in UIP, you see this basal predominance and no findings here in the rest of the lung indicating that you might be dealing with hypersensitivity pneumonia. Whereas in hypersensitivity pneumonia, you usually see quite a diffuse distribution, and the honeycombing not in a basal distribution. But then in addition to that, also usually you see some ground glass nodules or air trapping. So this would be highly suggestive here of a UIP. Again, just to remind you how these nodules look like in hypersensitivity pneumonia, if I would see that, then this would be my main differential diagnosis and not UIP. So here, the diagnosis here we can make is the one of a typical usual interstitial pneumonia pattern. And what we see as a hallmark, and it needs to be emphasized, we see reticular abnormalities and honeycombing as the main feature here in a basal and subpleural predominance. And to exclude the main differential diagnosis, we have this fourth point here. We look specifically for signs which would suggest other diagnoses, the main differential being here hypersensitivity pneumonia. And just a brief reminder, these criteria here were developed to diagnose IPF, idiopathic pulmonary fibrosis, with a high level of confidence. You see usual interstitial pneumonia also in connective tissue diseases. And here we see also sometimes not such a basal predominance as we see in IPF. So this is just a reminder that you should need to know that these criteria were not developed to diagnose UIP in all contexts, but in the idiopathic context. But that's the main feature here we see. And UIP is seen in a variety of diseases. It's seen in idiopathic pulmonary fibrosis. That's the most common cause for UIP, but it's also seen in some patients with scleroderma, typically seen in rheumatoid arthritis. You may see also a hypersensitivity pneumonia just presenting with a UIP pattern. Familial pulmonary fibrosis, drug toxicity, sarcoidosis, and asbestosis all may present with these features of UIP. So when we as radiologists say it is UIP, then the job of the rheumatologist and pulmonologist just starts, because you have to diagnose or exclude all the other diseases. Just for the ones of you who are not that familiar with that IPF, idiopathic pulmonary fibrosis, because the rheumatologists are not always familiar with that idiopathic form. It's a specific chronic progressive fibrosis of unknown cause. And without treatment, the median survival is between 2 and 3 years, which is worse than most tumors you will see in your professional life. So only lung cancer and pancreatic cancer have a worse prognosis, and the incidence with up to 20 per 100,000 is more than all brain tumors taken together. Very important here is age, as age gives us a clue. If I see that UIP pattern in a very young patient, I always doubt the diagnosis of idiopathic pulmonary fibrosis. I would more go towards the suspicion of a underlying connective tissue disease, yet unknown. So that's really important. But what if you do not see honeycombing? Let's see, just look at this case here. It's an 81-year-old male patient. And if I click you through these pictures, you will appreciate already down here, these reticular abnormalities, the crisscrossing lines. And you see here these rings. These rings correspond to dilated airways. And here in the periphery, you should not see any airways. If you see them, it's either the bronchial walls that are thick or they are dilated, as in this case, that's traction bronchiectasis. So I know already, looking just at this picture, that there's a lung fibrosis. And going up here now, you will probably agree that the apical parts don't look too bad. This is almost normal. I don't say normal, completely normal, but it's almost normal. And going down, you completely see this, clearly see this pronounced distribution in the lower lobes and dorsal parts of the lower lobes. But I don't see honeycombing. So honeycombing would be the most helpful clue here to diagnose of UIP. But as I don't see that, my differential diagnosis is much more extensive. It would also include non-specific interstitial pneumonia or also a hypersensitivity pneumonia. But remember, IPF is the worst situation. So what we are afraid of is this could be IPF. And that's why the criteria call this the probable UIP pattern. You must see that in a way, whenever I see as a radiologist a changes which look like a tumor, we call it tumor until proven otherwise, because that would be the worst situation, which would require a swift diagnosis. And that's what we do here. We say probable UIP, meaning you need to diagnose or exclude IPF. And probable UIP is defined with, again, the CT pattern, in this case, reticular abnormalities and peripheral traction bronchiectasis, but you do not see honeycombing. And you see this in a basal and suboral predominance. And again, you have this fourth point here to exclude other differentials. You look specifically for signs of hypersensitivity pneumonia. This is the main differential diagnosis. So the probability that this is, in fact, the UIP is quite high. In fact, it's between 80 and 90%. But that's probably not high enough to base treatment decisions on, because the main differential diagnosis would be non-specific interstitial pneumonia, which can look very, very similar. In fact, looks exactly the same on a CT scan. So again, as I discussed with you at the beginning, we try to avoid a biopsy. So what can we do to avoid a biopsy? Mainly, we go with the probability. And this is shown here, and don't take this too seriously. This data I took from the literature, but from two different sources, so that's not highly scientific, but it gives you a glimpse on what I mean with that. If you look at IPF, it shows a peak at around 67 years and a quite broad age distribution. It's quite a common disease as compared to other idiopathic diseases. And if you look at now at NSIP, idiopathic NSIP, it's much less common. And the age peak is around 56. So if you have a patient with that CT pattern of a probable UIP and the patient is older than 60, 65, the probability that you are dealing with IPF is very high. On the contrary, if a patient is younger, you do not know. This could be NSIP, which usually requires immunosuppression. And that's why the decision whether or not to biopsy is mainly based on the age. Another factor which we take into account is smoking history. IPF is a smoking-related disease, so that's also important. For that reason, the Fleischner Society, an international radiological or multidisciplinary society focused on thoracic radiology, stated in their guidance, if a patient is older than 60, a current former smoker, and has no history of other potential causes of fibrosis, meaning you excluded hypersensitivity pneumonia and a connective tissue disease as good as it gets, you can diagnose an IPF without a biopsy. And if the patient is younger, you should go for a biopsy because there are all these other differential diagnoses which would require other therapies. The new ATS guidelines published last year state essentially the same. So what is always important? Look at the clinical context. That's what leads you to the diagnosis. So to bring this together, and then we move on to more cases, is if you look at the lung fibrosis and try to make it very simple, you have three radiological scenarios in essence. One is you see honeycombing. The other one would be you see reticular and subpleural reticular abnormalities without honeycombings. And last but not least, you may see predominantly ground glass abnormalities. If you see honeycombing, we discussed it before, then your main differential diagnosis would be the typical UIP pattern as well as the chronic hypersensitivity pneumonia pattern. And UIP is predominantly a diagnosis of exclusion. If you exclude hypersensitivity pneumonia in a patient with honeycombing, and the honeycombing is a basal and subpleural predominance, you diagnose UIP. If you see central lobular ground glass nodules or air trapping, you consider hypersensitivity pneumonia. If you see reticular abnormalities in a basal and subpleural predominance, the differential diagnosis is quite broad. But you go with the age. If the patient is older than 60, a current or former smoker, and no history of potential causes of fibrosis, you diagnose UIP/IPF. If the patient is younger or non-smoker, you would consider other differential diagnoses and would consider a biopsy. And if you see predominantly ground glass, and this is very important for you as a rheumatologist, that's a common finding in rheumatological patients, your main differential diagnosis would be NSIP. But be aware, these are sometimes heavy smokers, so must not forget also smoking-related diseases, and one which looks very similar to NSIP is this quemative interstitial pneumonia or hypersensitivity pneumonia. And then Vanessa showed you this beautiful case of a lymphoid interstitial pneumonia also that may present with ground glass and may look very similar to NSIP. So that's why we need to discuss these cases in a radiological discussion. I would move on with a few more cases, and then we could discuss that. But I would like to bring that point home with how important it is to discuss everything, because there are so many pitfalls and interaction is everything. So that's a 32-year-old female patient with a newly diagnosed mixed connective tissue disease. And the CT was performed to exclude a connective tissue disease, ILD. So this is the CT scan here. And if you look closely, I was wondering, is there ground glass? And the answer is yes, because if you see, looking at the lung parenchyma, is much more gray than here. These dark areas, that's an airway, that's the right lower lobe. And usually the lung parenchyma is in the range of the lumen of the airways, but that's much more gray. So that's ground glass. And now it's easy to say and very, very misleading to say, if I see ground glass in a patient with a connective tissue disease, it must be NSIP. I discussed the potential differential diagnoses already with you, but there are more differential diagnoses. And just to give you a glimpse there, do not forget the presentation is super important. If this patient would present with acute symptoms, even if it has scleroderma or mixed connective tissue disease, I would consider differentials. Infections are important, like pneumocystis or a viral infection or a hypersensitivity pneumonia. We discussed such a case before. Or if the patient is older, also a hydrostatic edema would be my differential. And then there are also other differentials when it comes to subacute or chronic presentation. But I did not mention one differential diagnosis, and that's a pitfall which is super important, which is inspiration depth. The density of lung parenchyma depends heavily on the inspiration depth. If you take a deep breath, it's mainly lung which is in the lung parenchyma. If you breathe out, there's less air, and less air means lungs are denser and thus they become more gray, meaning you see ground glass. And this was the case in this patient. The patient did not understand the technician. She did not understand German and not any of our programmed languages in our scanner. And this was the expiratory scan we performed. And you see here, when we wanted to perform an expiratory scan, the patient did take a deep breath. So this is a common pitfall, and this is a very important pitfall when it comes to follow-up examinations. Your radiologist needs to compare the inspiration depth before analyzing any changes in ground glass. And this is something which many radiologists are not used to do. And this leads to potential overdiagnosis or misdiagnosis of disease progression. Be aware of that and show, in case of doubt, at least show these cases to your expert radiologist. Okay. Then a few more cases which are important to show that a 74-year-old female patient, again with polyarthritis, dizziness, fever, dyspnea, and she comes in now to perform imaging. And you see here the chest radiograph does not look nice. You see this elevation of the diaphragms, but that's just one plane. I don't know if that's really corresponding to a loss of volume because I don't have any lateral. And if I look here at the CT scan, I see again lots of ground glass. Look here, this is way too dense. Everything is very, very dense. So could this be a disease related to the connective tissue disease, rheumatoid arthritis in this case? And if you followed my discussion before, what is super important to us is not just the changes in the lung parenchyma, in this case this patchy ground glass, but also distribution. The distribution here is diffuse. That's not what I would expect in a connective tissue disease. So my differential diagnosis would be more extensive. And now, as this patient is presenting with acute symptoms, my differential is completely different. Infections need to be taken into account: pulmonary edema, hemorrhage, hypersensitivity pneumonia. And Milena discussed it before. What we see in rheumatoid arthritis as a treatment reaction in methotrexate is acute hypersensitivity pneumonia. And this was such a case which a patient with undergoing methotrexate therapy with hypersensitivity pneumonia as his disease presentation. So this was just a brief walk through CTD manifestations, and I wanted to give you some time to answer questions, so I would stop here and open to question, and then we have many more cases for the next hour to come. So happy to take questions for your side.